So welcome, everybody. We're going to get started here with another one of our sessions as part of the 2021 Insights World Tour represented by Ortho Evidence. And here we are doing a virtual stop in the United Kingdom. Let me remind you just briefly a little bit about some of the what the Insights World Tour is. So this is a series of limited capacity online events. As you can see, it's a small group of us. This is not webinar style, but more of a conversational style. And we look at topics of interest with keynote speakers of international repute, as well as an amazing panel this evening, an international panel that will be able to engage in some discussion. This event is recorded, and we will hope that during the presentation period that you'll stay off video and muted. Thereby, once we're finished this presentation, we'll request all of you to come back on video and we can have a robust discussion. We have a great session in planned, and I look forward to the ability to share this with you. So this evening and this afternoon, we have a very special lecture on a very topical area, FAI, or femoroacetabular impingement. Where are we now? So as you can see, it's going to be a real evaluation of the history, the diagnosis, management, and clearly evidence at the forefront of this discussion. We have an amazing keynote. I'm grateful that he can be with us today. So he doesn't need an introduction to many of you, but certainly Professor Khanduja, who, as you can see, is the Hunterian professor in Cambridge University, as a consultant orthopedic surgeon and a research lead, and has a host of other roles, numerous roles in international societies and leadership in international societies. So I could spend many a day discussing all his accolades, but unfortunately, we only have an hour. We have an amazing group of panelists who will join us as well, and I will let Dr. Khanduja speak to you about who they are as we move forward. So without further ado, it's my great pleasure and honor to present to you Professor Khanduja on the femoroacetabular impingement story. And off with you, Vikas. Thanks so much.
Thank you very much indeed, Mo, for the kind introduction. And first and foremost, I'd like to introduce my panelists for this evening who've actually taken the time. And it's pretty late in mid-Europe, so thank you very much. First of all, it's Nicolas Bonan from France, Lyon. Thanks, Nico, for joining in. Secondly, it's Oliver Marin-Pena, good friend from Madrid, Spain. Thanks, Oliver. We've got Thanos from Thessaloniki, Greece. Again, pretty late out there, so thank you very much, Thanos, for joining in. And finally, we've got Sunil Kumar, who's our hip preservations fellow in Northumbria currently, who's joined us as well, giving us the trainee perspective. So thanks a ton for all of you joining in. I'll just share my slides and we'll kick off. So there we are. I'm going to spend the next 20 to 25 minutes talking about is femoroacetabular impingement. Where did we start and where are we now? Thank you very much, Mo, for this exciting event that you host, and thank you very much for inviting me to this as well with all our panelists. These are my disclosures, and I bring you warm greetings from our biomedical campus in Cambridge. So what I'd like to cover really is what exactly is femoroacetabular impingement, how does it present? Probably these two you're well aware of. How is it managed? How is it changing, or how has it changed over the last 3 to 5 years, and what are the advances and direction of future research? And this is probably going to be the topic of our discussion at the end of the talk for the next 20 to 25 minutes. So this paper really changed our thinking about hip pathology. This paper comes from Gans and his colleagues in Switzerland, and they make a fairly bold statement that femoroacetabular impingement was a cause of early osteoarthritis of the hip. Now, although this paper came in only in the late 1990s, early 2000, we knew about femoroacetabular impingement, or it existed in some form or the other right from 3000 BC, since essentially the morphological abnormality of the hip existed. But it's only since Gans described it in late 1999 that it actually picked up and the interest grew significantly. So whatever we thought as the classical pistol grip deformity, which the picture which we saw in our textbooks was potentially CAM type of impingement, actually leading to arthritis in the hip joint. And then since 1999, the number of publications on PubMed have soared rapidly, over 3,500 publications now, just if you type femoroacetabular impingement in PubMed. And this year alone, we've seen over 460 publications in the subject. If you look at the number of hip arthroscopy procedures, again, concomitantly in terms of the number of publications, you can see the growth of hip arthroscopy. This is the UK alone. The last decade, we've seen grown over 700%, and the projected growth over 1,400% by 2023. So what exactly is femoroacetabular impingement? So Professor Gans and his colleagues described it as basically a painful contact which occurs between the femoral neck and the acetabular rim, which occurs within the physiologic range of motion of the normal hip. And it could be a problem on the acetabular side, so where you've got a protrusio or a retroverted acetabulum or an anterior overgrowth, and that is the pincer type of impingement. Or it could be a problem on the femoral side, where you've got a proximal femoral deformity or abnormal anatomy, and that's called CAM type of impingement. Or it could be because of overuse of a normal hip, for example, in a ballet dancer. So here's what a CAM impingement would look like. The patient would, don't tell me this doesn't work. This would be a real shame if I can't get this video to work. Okay, so we'll have to cope with this. This video is not playing, but essentially in a CAM type of impingement, you've got a large lesion on the anterolateral aspect of the head-neck junction. And essentially when the patient would actually flex their hip up, that would impinge onto the labrum and the labrochondral junction. And over a period of time, the labrochondral junction actually disrupts, and then the articular cartilage starts peeling off, or the anterior aspect of the acetabulum, thereby leading to arthritic change. Now, who actually develops CAM type of impingement? Now, athletes are at a higher risk. About 48 to 75% of the male athletes display CAM type of morphology. Female athletes, less so. And in our paper recently, we've seen that is potentially developing around the 11 to 14-year age group, especially in those who are actually indulging in rugby and football on a regular basis. So the adaptive theory may well be responsible for that. In terms of pincer impingement, the best way to think about it is the pincer grip of the crab. That is how the acetabulum will actually hold the femoral head-neck junction. Again, I hope this video works. Okay, this is letting us down here, but essentially there'll be a retroverted acetabulum or an anterior overgrowth of the acetabulum. And when the patient would flex their hip up, there would be impingement because the femoral head-neck junction would impinge against the labrum. Now, the concept here is different as opposed to the CAM, because when the patient flexes, it's a linear contact with the labrum, and the repeated linear contact actually leads to calcification of the labrum over a longer period of time. And therefore, the space available for the femoral head to move in the acetabulum is reduced. And over a period of time, because of the constrict coup lesion posteriorly, it may lead to arthritic change in the hip, usually seen in the middle-aged females. So based on this, the femoroacetabular hip impingement syndrome described by the Warwick group has come into place now. So essentially, if you've got the symptoms, that is pain in the groin with the classical C sign, the impingement test, that is flexion, internal rotation, and adduction causing pain, along with the radiological signs as well, then that actually constitutes to the femoroacetabular impingement syndrome as we all know it and well described now. The impact of it is huge. They have pain and disability, obviously, in this young adult cohort. Some of them can actually develop osteoarthritis as well. Obviously, because it's happening in the young adults, the economic profile is actually reduced as well, because most of them are contributing significantly in this age group to the economic profile, not only to their own households, but the nation as well. And there is a significant psychological impact as well. So huge in all these four areas. Therefore, the goal of treatment in these patients is joint preservation and actually work on all those 4 areas that are being inhibited. Now, in terms of investigations, you'd obviously get the standard AP and the cross-table laterals, but the game changer for us has been the 3D CT recons. That allows you to see what exactly is happening on a 3D aspect on the febrile head. You can pick up where exactly the cam lesion is, allows you to see what exactly is happening on the anterior inferior iliac spine and whether there is an element of subspinous impingement. What is the acetabular coverage? So certainly the 3D CT recon is the game changer. And more importantly, we can look at the posterior joint space. And a lot of the times when the anterior joint space is still pretty good, the posterior joint space is reduced. And potentially those are the patients that we probably should not be operating upon because there is significant damage there already. And then investigations like this derived from the CT, these are the collision analysis scans developed by the clinical graphics group, actually tell you where the impingement is, especially in which direction, which motion. And more importantly, it will also give you a reasonable analysis of how much we need to excise and from which area to cause impingement-free range of motion. Again, this is only bony. It is bony collision analysis. It does not have the soft tissue, but that it tells you how much we need to take off to get that impingement-free range of motion for that particular patient at that time. The diagnostic hip injection we found fairly useful. And in essence, most of the patients who present to us would probably be presenting with pain for a long period of time. So we find that injecting them with some sort of local anesthetic and steroid and ensuring that the pain is actually coming from the hip is both a good diagnostic and a good prognostic measure as well before actually intervening with arthroscopic intervention or otherwise. Now, in terms of management, we'd obviously start with conservative management because as we are well aware, there is a group of muscle which is affected in femoroacetabular impingement, and only if they have failure of conservative management would we think of intervening surgically. The other thing we need to think of is the morphology. How bad is the impingement in terms of the cam and the pincer, and the dynamics of impingement, i.e. who's actually having that impingement. So if a surgeon like me has a large cam impingement and I'm not going to be using my hip in terms of deep flexion and rotation for most of my activities, then I may be able to survive, my hip may be able to survive without actually any surgical intervention. But equally, on the other hand, if this Chinese ballet dancer, and I really pray that this video works, oh, that's brilliant, it does. So if that Chinese ballet dancer, just laboring the point, had a small cam lesion, she would definitely be struggling. And she definitely needs a full rotation and a full function of her hip in terms of movement to actually do her job. So that is the one, if she does not settle with conservative management, she'd probably require surgical intervention. So it's not only the morphology, but it's also what you do with that hip and the dynamics of that hip that is responsible in making. Now, if you look at the surgical technique, then in terms of what we are trying to address, the first thing is improvement of joint mechanics. So we correct the head-neck offset, we get the correct waist, and then recess the rim. And then we address the soft tissue through labral debridement or repair or reconstruction, and then address chondral damage subsequently if required for that patient. So when Gans described it initially, he essentially looked at open surgical dislocation through a trochanteric flip osteotomy And you could address the cam impingement, you could address the pincer impingement, both at the same time. So there's that. You take a high-speed burr and take the cam lesion off, and then you address the pincer one. But obviously enter hip arthroscopy, and pretty much you could do the whole procedure now exactly as Gans described it through arthroscopic intervention. So you could start with the labral repair. So that's the labrum. You can see the gap there. It is coming off the acetabular edge. You could pretty much use anchors like the shoulder to repair that labrum. And then you can address chondral damage through techniques like microfracture, or now there are enough chondral filler techniques available as well if there is significant amount of damage in that chondral area. And finally, you can address pincer, again, arthroscopically, image guided, and take off the impingement lesion on the pincer side as well. And finally, the cam impingement through the peripheral compartment. Again, you could actually use high-speed burrs to take the cam impingement lesion off after assessing it through the peripheral compartment, and then do a dynamic impingement test on table to make sure that there is enough of a gap left between the labrum and the head-neck junction, and there is enough clearance there. So exactly as Gans had described it through the open approach, you could actually achieve it through the arthroscopic approach. Now, doing it through the arthroscopic approach, let's look at the outcome data and what are the various outcome tools that have been available to us in looking at this. So obviously, we've got a registry going since 2012. We've recently had the 6th annual report, which was presented. So I'll share a few slides from there. So the number of pathways has been increasing, and we've got over 15,000 pathways now on that registry, 15,607 in this report. And the number of surgeons, unique number of surgeons of contributing to the registry throughout the UK is 106. And you can see the clear age distribution. So majority of the operations that are being done are between the ages of 15 to 45. Most of them arthroscopic approach, and that's what we would see. But have a look at this slide. This is probably the most important thing, which tells you the outcome data. So we measure it through something called the IHOT-12, which is a specific score for young adults with hip pathology. So this is where they're starting off pre-op, a 6-month follow-up, jumping from 32.8 to 56.7, which is MCID is about 12. So it's certainly got enough points on there to clear the MCID, and then it's being maintained to 12 months as well. This is for FAI whole cohort at the end of 1 year in EQ5D. And if you break it down to the cam lesion alone, then we're seeing a similar effect at 6 months and 12 months. And again, on the EQ5D, that's the generic score. And then again, on the pincer side, if we break it down, we're seeing a similar effect, a jump in the IHOT-12 from pre-op to 6 months to 12 months post-op. And again, similar effect seen on the EQ5D. So that's as far as registry data is concerned, with more than 15,000 patients on the registry for hip impingement. Now, if you look at 2 large-scale randomized controlled trials, both come out of the UK. One is the Fashion trial, which comes out from the Warwick group. They compared hip arthroscopy versus physiotherapy for patients who've got FAI with earlier no arthritis. And essentially that showed that if the patients in the surgical arm or the arthroscopic intervention arm did much better than the physiotherapy arm, but in the shorter term, and that was published in the Lancet. The second one, which is a similar trial, the FATE trial published in the BMJ, coming from the Oxford group, which we contributed to as well. Again, similar arthroscopic surgery comparing with physiotherapy and activity modification for symptomatic femoroacetabular impingement. But again, with no arthritis, we're seeing that in the shorter term, surgery does much better than physiotherapy for these patients. So these are the 2 large-scale randomized controlled trials, multi-center, which tell you that surgery is doing better than physiotherapy in the shorter term. But when you're sitting in the clinic with your patients, the questions that they ask you would be, will this procedure cure me? Or does it stop me having a hip replacement in the future? Or how long will it last? And what are the long-term outcomes? Now, these are the questions which actually will bug most of us hip preservation surgeons when you are discussing this with the patient's clinic. So short-term outcomes, both on registry and randomized controlled trials being good, but what's happening long-term? So we did this with a couple of fellows and HM Albia up in Northumbria. So does hip preservation surgery prevent arthroplasty? And we wanted to quantify the rate of conversion to arthroplasty following hip preservation surgery. So we looked at all the papers actually that were published, followed the PRISMA guidelines, looked at search all the databases up to November 2018 and used the minors criteria and scored them. Started with 1462 papers, finally had 62 articles included for full discussion and analysis. If you look at the levels of evidence, again here, about 3A6 and majority level 4 evidence, and mean minor score 10 and 17 for non-comparative and comparative. Total number of hips that we had, about 59,000. Conversion to total hip arthroplasty, about 5,600. Mean follow-up, about 46 months. And mean time to conversion, about 24 months. So conversion rate of about 9.4. And that is, that's earlier on. It's about 24.4 months. And the factors, if you look at it, certainly age is a factor. If you're operating on patients more than 40, significant chance of them getting conversion to total hip arthroplasty. Again, osteoarthritis, mild versus moderate and severe. Patients who've got moderate and severe arthritis, again, high chances of getting conversion to an arthroplasty. And again, joint less than 2 millimeter joint space, higher chance as well. And all these were statistically significant. But obviously, the limitations of this are that we're limited by the quality of the data available, and not all clinical features will, not all clinical failures in this group will actually go on to having a total hip replacement. So there'll be patients who are in pain but do not have a hip replacement. But certainly it tells you that we should not be operating on patients who are over 40 with significant degree of osteoarthritic change and joint space narrowing. But techniques are evolving. We started off with the debridement, and pretty much most of the patients who were in this series probably had a debridement. We've gone on to acetabular labral repair, and now we're doing a lot of acetabular labral reconstruction. So as techniques have evolved, probably the results will get better as well. And the other thing to highlight here is that not only the techniques of handling soft tissue, but the techniques of excising the cam lesion and the pincer lesion have evolved as well. We hope that we are excising our cam lesions a bit better and more accurately. So this is a paper that we published recently where we looked at a few patients from the, we had done a randomized controlled trial where we looked at conventional versus navigated hip arthroscopy. So we took a cohort of the navigated hip arthroscopy group who had perfect resections of the cam lesion and subjected them to discrete element analysis to look at the forces going through the hip joint. And basically, if you do a clear resection of the cam lesion, an accurate resection, then you're restoring the normal peak joint contract stresses in the joint. And this is a good surrogate marker to tell you that if you do your surgery accurately and correctly, then potentially you normalize the hip stresses and hopefully obviate the need for a joint replacement in the future. But essentially, if you look at the next 5 to 10 years of research, it's all about picking winners and stratification. We need to look at which are the patients who are going to do well with arthroscopic intervention for FAI. And we're clearly seeing that those patients who've got either acetabular cysts or bone edema, those patients who've got mental health issues, patients who are not going to buy into a full period of physiotherapy, and who've got hyperlaxity are potentially the patients who may have less favorable outcomes following arthroscopic intervention. And these are probably the patients that we need to be avoiding surgical intervention for. Again, we need to be very careful about rotational abnormalities, and these should be measured on the 3D CTs previously. And those who have rotational abnormalities probably require an osteotomy rather than arthroscopic intervention. But the problem is increasing because we do see a problem on both sides. We have, this is thanks to Ben Lund, this image, where we've got inadequate excision of CAM lesions. About 25% of the primary CAM resection surgeries are incomplete. 5 to 10% of all hip arthroscopies require revision arthroscopy. About 80 to 90% of all the revisions are for residual FAI, and certainly there's no evidence of CAM regrowth. So it could be both a problem on under resection or over resection. And the reason that is because there is a failure to understand the anatomy of the CAM, because it's a three-dimensional lesion, a failure to access the whole CAM arthroscopically, failure to understand the dynamics of the CAM and in whom you need to be operating, and then failure to address the learning curve as well. And we need to ensure that all these are looked after in the future, both in terms of research and practically as well. So certainly personalized and accurate CAM resections based on a clear radiological model, 3D CT, along with collision analysis, and probably biomechanical data for specific individuals who, for example, jockeys or those who are engaged in rugby or football is essential before you operate on these patients, because you need to normalize their forces, and probably DEA scans as well to ensure that we are normalizing the peak stresses in the joint is probably the way forward for hip impingement. So if we look at our own young adult hip research program, we are certainly focused on optimizing outcomes in hip arthroscopy. And if we look at the surgical risk factors, which will optimize outcomes, then it's stratification of disease, looking at first in the CT scans and then looking at outcomes. And this MPhil and PhD being done by Mr. Sunil Kumar. The second aspect is looking at biologics for early OA and doing a FATE2, that is for FAI plus TONIS 2 or TONIS 3 OA, and seeing what are the outcomes there. And then surgical precision, that is navigation and robotics, looking at if we are able to ensure that we have accurate resection through robotics, what are the outcomes in comparison to conventional hip arthroscopy going forward. And then the non-surgical risk factors play a significantly important role as well. That is optimizing muscle strength, role of prehabilitation, and role of mental health. So that's what we are focused on over the next 5 years in terms of optimizing outcomes for FAI. And this is what potentially the future is looking at, smart imaging. So we've got dynamic MRI, which will tell you, again, I can't get this to work, unfortunately, but this will tell you exactly what's happening to the labrum at 30 degrees of flexion and 60 degrees of flexion. You'll be able to subtract the joint space and again stratify the disease preoperatively to decide whether this patient needs surgical intervention or not. And for complex deformities, looking at 3D printed models before we actually operate on them to optimize our surgical intervention. And then a huge amount of emphasis placed on decreasing the learning curve. So we've got a fairly well-established hip arthroscopy training program with the fellowship in young adult hip surgery, cadaveric skills training coupled with simulation training and mentored independent practice after that. We've trained a few surgeons around the world and have had many visitors as well. So in a nutshell, ladies and gentlemen, that's what I wanted to speak to you about femoroacetabular impingement and where the research is headed to. Happy to share these papers and some chapters from the book as well going forwards. But in essence, it's a complex interplay between the morphology of the patient, the activity and the dynamics that the patient is involved in, and finally the genetics as well. And all three need to be taken into consideration before you're able to offer these patients surgical intervention or otherwise to ensure you have appropriate outcomes. So we've certainly come a long way in terms of understanding what FAI is all about, and the future, a long way to go. We're only beginning to get early and midterm outcomes. Certainly, as I said, a disease stratification with automatic segmentation and calculation of angles and indices, and AI will certainly help us in developing prognostic algorithms. Robotic arms for precision surgery are definitely the future to make sure that we are getting it to the millimeter right. We also need to look at genetics, because not everybody with femoroacetabular impingement will develop osteoarthritic change, and certainly genetics need to be looked at carefully and then stratify disease based on that. On that note, a big thank you to Mo for inviting us to this panel, and I'll stop sharing my slides and we'll bring it to the question time and the discussion time. Thank you very much indeed.